everybody. It's my pleasure to start Ain Shams Neurology Expert Academy. My name is Hani Arif. I am the head of the Neurology Department at Ain Shams. This is part of the continuous educational program, and we have the pleasure to continue this program across the year. We have in our department 7 units, so each unit will have 3 successive meetings with one of the top experts in the field. We will start with the stroke unit, and it's our honor and it's our pleasure to have with us in the first wave Professor Diener. I will introduce Professor Diener, but we'll have just a short break for 30 seconds and we'll continue again. Let me introduce Professor Hans-Christoph Diener. He is one of the top experts in the field of stroke. Professor Diener is the head of the department in the Essen Institute for Medical Informatics, Biometry and Epidemiology in Germany. He authored and co-authored more than 800 articles in peer-reviewed journals, 19 of them in the New England, and he wrote 311 invited reviews and 332 book chapter. Actually, Dr. Diener is having a very long biography. If I will go on, it will take maybe half an hour to review his biography. His main interest in the field of stroke and in the field of headache, and he was a principal investigator of many studied in these fields. He will talk us today about the ESUS. Actually, he contributed and he shared this story from the very, very beginning. And he was one of the players and the main founders of this event term, and of course contributed in many of these trials. So he will take us through this journey, how it started and how it progressed and how it's likely to evolve. Also, it's my great honor to share the moderation with my colleague from Saudi Arabia, Dr. Saeed Al-Ghamdi. He's the president of the Saudi Stroke Society. He's assistant professor of neurology in King Abdulaziz Medical City, Jeddah. It's my great pleasure to share this session with him. And we are looking, of course, for more and more cooperation in the field of stroke across the region. Now the floor is yours, Dr. Diener.
Yes, so thank you very much for the kind invitation. I think all of you can imagine I would have preferred to come to Egypt, in particular with the new museum, which is now almost ready in Egypt. And in the past, I used to travel a lot in the Middle East, including Saudi Arabia. So my topic today is the embolic stroke of undetermined source story. And this presentation is a joint venture between myself and Bob Hart from Canada, because the two of us developed this concept of ESUS. This is my conflict of interest statement. The majority of my funding comes from the German Research Council. So let me take you back many years. This was the original TOS classification, where we had about 25% of all strokes were due to large vessel disease, 20% had a cardioembolic source, in most cases atrial fibrillation, 25% were lacunar strokes due to poorly controlled hypertension and diabetes. And then we had rare diseases like dissection migraine, vasculitis, and so on. And then we had an entity called cryptogenic, and this means we didn't know what the cause of the stroke was. So Bob Hart and myself, we developed a protocol where we wanted to compare oral anticoagulation with aspirin in patients with cryptogenic stroke. And we submitted this protocol to the Food and Drug Administration in the United States, and they invited us for a hearing. And the bottom line was, they said, you are idiots because you want to study something where you don't know what it is. Because cryptogenic stroke basically means you don't know what the cause of stroke is. So go home and come up with an operational definition of the population which you want to study. So we had a 2-day meeting at the NIH in Washington, and we invited lots of neurologists, stroke neurologists, cardiologists, and we came up with this new entity called embolic stroke of undetermined source, or ESUS, and we published it in Lancet Neurology in 2014. So ESUS is a subgroup of cryptogenic stroke, because cryptogenic stroke can also mean if the diagnostic assessment is incomplete, for example, the doctor doesn't do an ECG or echo, this would still be called cryptogenic. And ESUS basically means it's definitely not cardioembolic, it's not large vessel, and it's not small vessel disease. And these are the criteria and the investigations you have to do. So number one, you have to show that the person has a stroke on brain imaging, and the stroke cannot be a lacunar stroke. Then you have to do CT angiography, MR angiography, or ultrasound to exclude a more than 50% stenosis of the carotid arteries, of the vertebral arteries, or the intracranial arteries. And then as a minimum, you have to do 24-hour ECG recording and echo to exclude a cardiac source of embolism. Now, at least in Europe, standard of care now is 72 hours of ECG recording or monitoring on the stroke unit. And then you have to exclude all the rare causes of stroke. Now, we submitted our protocol to all the companies which produced NOACs, and 2 of the companies agreed to have a randomized trial. So I decided to go with Boehringer Ingelheim, and Boppard said he would go with Bayer and Johnson & Johnson. So let me start with the ReSPECT ESUS trial, the first trial, and both of these trials were published in the New England Journal of Medicine. So let me remind you what the design was. We had patients with ESUS, embolic stroke of undetermined source, and we randomized them to either aspirin or to either of 2 doses of the dabigatran. And the hypothesis was, if these strokes are due to an embolic mechanism, then anticoagulation should be superior to aspirin. And we didn't want to have a high bleeding risk. This is why we compared a NOAC with aspirin and not warfarin. Now, the dose of the dabigatran was adapted to the age and renal function. So people above 75 years got the low dose, and people with a creatinine clearance below 50 milliliters per minute. The primary efficacy outcome was any stroke, which means ischemic and hemorrhagic stroke, and the primary safety outcome was ISTH, major bleeds. The study lasted on average 19 months. Now, these are the baseline characteristics. You can see we had about 2,600 patients in each group. They were on average 64 years old. About 1/3 were females. The majority had a high CHA2DS2-VASc score, so a high risk of a recurrent stroke. Many of them had hypertension, 20% had diabetes. Now, this was the primary outcome. The gray line here is the event rate for aspirin, and the blue line is the event rate for the 2 doses of the dabigatran. The annual rate of stroke was 4.1% on the dabigatran and 4.8% on aspirin, and this translated to a 15% relative risk reduction, which unfortunately was not significant. But it's interesting to see that beyond 1 year, the curves started to diverge. Now, we did something which is called a landmark analysis. And this means you separate the results half time. So after 360 days, This is the event rate for aspirin. This is the event rate for the bigatran. And if we look at the statistics in the first year, there was no difference whatsoever between the bigatran and aspirin. In the second half of the study, we had a risk reduction of 50% in favor of the bigatran, which was significant. But overall, unfortunately, the study was neutral. We recalculated how long would we have to extend the trial to have a positive result. And if this trial would have gone on for 2 more months, the study would have been positive. But unfortunately, it's neutral. So we also looked at secondary outcomes like ischemic stroke. There was a benefit for the bigatran, which again was not significant. And also the composite of non-fatal stroke, non-fatal MI, and cardiovascular death. But we had a significant benefit to reduce disabling strokes. So there were 25 with the bigatran and 42 with aspirin. Mortality was not different. Then we looked at different subgroups. These were all pre-specified. You can see there was no impact of male or female sex. There was a benefit, interestingly, in patients from Asia, and this was even significant, for example, in Japan. There was no difference whether a patient had patent foramen ovale or not. And then we also looked at different ages, and here you can see the benefit of the bigatran over aspirin is age dependent. So in patients above 75 years receiving the low dose of the bigatran, there was clearly a benefit of the bigatran over aspirin. And this is also shown here where we look at the dose. Remember, patients above 75 years would get the low dose, and this explains why the low dose was significant. The high dose was not different from aspirin. Now, this is the distribution of the modified ranking scale, and you can see there was a significant benefit to prevent disabling strokes for the bigatran over aspirin. Now, whenever you compare anticoagulation with aspirin, your major concern is bleeding. And when we looked at the rate of major bleeds, again, this is aspirin, this is the bigatran, both doses, and fortunately, there was no difference. So the bigatran, and this is very reassuring, if you use the bigatran, for example, for atrial fibrillation, at least in this population, had a similar bleeding risk like aspirin. Now, if we look at major bleeds, there was no difference in major bleeds. There was no difference in intracranial bleeds. There was no difference in GI bleeds. There was a strong trend to reduce fatal bleeds. You can see here 1.17, the hazard ratio. 1 case on the bigatran, 6 cases on aspirin. And then we had a number of subgroup analysis, and all of these were predefined, and some of them are already published. So we first looked at the subgroup depending on age, and if we compare the bigatran with aspirin, again you can see the benefit of the bigatran in people above the age of 75. There was no price to pay. These people didn't have an increased risk of bleeding for the bigatran over aspirin. And then we looked at renal function. Now this is decreased renal function, and you again have a strong trend for the bigatran to be superior to aspirin. No difference in major bleeds depending on renal function between the bigatran and aspirin. And then the dose of the bigatran, 110 was superior to aspirin, 150 milligrams twice daily was equivalent, as you can see here. And again, no difference in major bleedings between the 2 doses of the bigatran and aspirin. Here we plotted age and renal function as a continuous variable. This is 30 years old, this is 90 years old. And here you can see the hazard ratio, which basically shows the benefit. And you can see that above 72 years, it becomes significant. So the older the patient, the more likely the ESUS patient would benefit from the bigatran. And the same is true, as you can see here, with declining kidney function. So if the creatinine clearance is below 75, there is a benefit of the bigatran over aspirin. We also looked at how many patients developed atrial fibrillation, and you can see the rate on average was about 7%. This is both for the bigatran and aspirin. And if the patient was on the bigatran, the risk of a recurrent stroke when these people developed atrial fibrillation and then they were taken out of the study was lower for the bigatran than for aspirin. Now, we were interested to develop a prognostic model. And what were the predictors of developing atrial fibrillation? There is no surprise. The most important predictor was age. The second most important was hypertension. And then it was renal disease. And we just submitted a paper where we looked at a multivariate model of this. Again, the most important predictor to develop atrial fibrillation is age. And most probably this explains why for people above 75 years, the bigatran was superior to aspirin because they had a much higher likelihood to develop atrial fibrillation over time. We also looked at biomarkers, and the only biomarker which was highly significant was pro-BNP. And if you had an increased pro-BNP, your odds ratio to develop atrial fibrillation was 4 times higher compared to patients who had normal pro-BNP. So with these parameters, like age, hypertension, and pro-BNP, you can most probably predict whether an ESUS patient has a high risk to develop atrial fibrillation, and then it's worthwhile to monitor the ECG on a regular basis. So in summary, what we learned from RESPECT ESUS, overall, the bigatran was not superior to aspirin for the prevention of stroke. And the good news, the bigatran did not increase the risk of major bleeding compared with aspirin. Now, this was the first randomized trial where the dose of the bigatran was adjusted for age above 75 and compromised renal function with the 2 doses. But this means at present, we don't have to change our guidelines. Standard of care in future, or at present at least for ESUS, is aspirin. Now let's move to Navigate ESUS. This was a study sponsored by Bayer and Johnson & Johnson. Again, patients with ESUS, 7,200, they were randomized to aspirin or to a reduced dose of rivaroxaban. Remember, for atrial fibrillation, the dose is 20 milligrams once daily. This study used 15 milligrams once daily. Primary outcome, like in RESPECT ESUS, stroke, and primary safety outcome, ISTH major bleeding. Now, this trial was terminated halfway through because rivaroxaban had an increased risk of bleeding compared to aspirin. Now, this is the efficacy outcome, and there is no difference, as you can see, whatsoever between rivaroxaban and aspirin. But remember, the trial was stopped here. And at this point in time, we also did not see a difference between the bigatran and aspirin. We only saw it when the time was extended. But the reason to stop the trial was this difference in major bleeding. 62 cases on rivaroxaban, 23 on aspirin, hazard ratio 2.72. And this was statistically significant. They also looked at subgroups. There was no influence of age in this study compared with the RESPECT ESUS study. And there was also no real difference in terms of geographic regions. So in contrast to RESPECT ESUS, patients in East Asia did better on aspirin than on rivaroxaban. They also didn't show any difference in the severity of stroke. So there was, for example, no benefit in preventing disabling strokes. Now they looked carefully at participants who had a PFO. And if these were not candidates for PFO closure because they were older than 60 years, they could go into the trial. And in TTE, they identified a PFO in 4.6% of the patients, and with TEE in about a quarter of these patients. And then they looked at the benefit of rivaroxaban over aspirin in people with a patent foramen ovale. And you can see here, this is the event rate on rivaroxaban, this is the event rate on aspirin. And they found a risk reduction of almost 50% for rivaroxaban over aspirin in patients with patent foramen ovale. And then they published in Lancet Neurology a meta-analysis where they took the PICS data, the CLOSE data, which was a PFO closure trial, and CLOSE, we had a subgroup of patients on anticoagulation compared with aspirin and Navigate ESUS, and they found a significant 50% risk reduction. I received the manuscript for review, and I asked the editors to not yet publish it, but wait for 6 weeks until we had the results of our trial. Then we could have done a real meta-analysis of all the data. And again, let me remind you, in respect ESUS, we had no benefit of the dabigatran over aspirin in people with patent foramen ovale. Now, this is the updated meta-analysis, which is accepted for publication in Stroke. This is respect ESUS, Navigate ESUS, PICS, and CLOSE. And in aggregate, you can see there is no longer a statistically significant benefit of anticoagulation over aspirin in patients with PFO. So if a patient with PFO doesn't qualify for PFO closure, the recommended therapy is still antiplatelet therapy and not anticoagulation. Now, Navigate ESUS also looked for predictors of stroke, and they looked for predictors of atrial fibrillation. And they found one very important predictor, and this is left atrial diameter. And left atrial diameter basically indicates left atrial cardiopathy. And if the left atrial diameter was more than 4.6 centimeters, there was a statistically significant benefit of rivaroxaban over aspirin. So obviously, left atrial cardiopathy is a very important predictor of recurrent stroke, and this explains why anticoagulation had a benefit over aspirin in this subgroup. And they published this in JAMA Neurology, though these are people here who have a atrial cardiopathy. This is the event rate on aspirin, this is the event rate on rivaroxaban, and here are patients who do not have atrial cardiopathy on echo, and there is no difference between rivaroxaban and aspirin. And then they looked at other parameters, for example, whether it plays a role, whether you have a below 50% stenosis or you have atherosclerotic plaques. This had no impact on the recurrent stroke rate, whether you were treated with rivaroxaban or with aspirin. Now, from all the subgroup analysis they did, the only one which was really significant and very importantly so was left atrial cardiopathy. So the main result, like in our study, ESUS has a high risk of recurrent stroke. It's about 5% per year. And they showed in their study 3% atrial fibrillation. We had 7%, but remember, in Navigate ESUS, long-term recording of ECG was not allowed. And again, this was a neutral study. So let's look what are the possible differences and the similarities between these two trials. And this is taken from this paper. So for example, if you look at age, the age was similar. But what is the major difference of these two trials compared to the AF trials? It's age. In atrial fibrillation, the mean age in these studies was 75 years, and here it's 65 years. But otherwise, all the other baseline parameters were the same, whether it was comorbidity or, for example, the percentage of people with patent foramen ovale. Now, if we look at hemorrhagic stroke, there was clearly a difference, because on aspirin in Navigate ESUS, it was 0.1%, and in Respect ESUS on aspirin, it was 0.7%. But remember, these patients had exactly the same risk because they were identical at baseline. And this is very difficult to explain. Also, if we compare the Averroes trial, where apixaban was compared to aspirin in patients with atrial fibrillation, aspirin had a rate of hemorrhagic stroke of 1.3%. We had a rate of 1.2%. So I think our data on aspirin reflects what's really happening. So I have no idea why in Navigate ESUS there was such a low risk of hemorrhagic stroke and intracerebral hemorrhage on aspirin. Is it the end of ESUS? I don't think so, because we have two ongoing trials. And this is the most important one, which is ongoing. This is Atticus. And Atticus compares apixaban with aspirin in patients with embolic stroke of undetermined source. This is not industry-driven. It's paid by the Food and Drug Administration. And they, by purpose, have a population which has a high risk to develop atrial fibrillation because they have cardiopathy of the atrium. This is Arcadia. In Arcadia, in order to go into Arcadia, you need evidence of atrial cardiopathy. And this is either done by echo or it's done by ECG, or you need a high pro-BNP. Now, this study is ongoing. Unfortunately, it's poorly recruiting. This is a German study. And this study also compares apixaban with aspirin, but Atticus has a surrogate parameter. So they do MRI in all of these patients at baseline, and they repeat it after 1 or 2 years. And the primary endpoint are new ischemic lesions as detected by MRI. Now, this study has recruited now 400 out of 500 patients, but unfortunately, I think it's underpowered to show efficacy. Now, as you can imagine, the results of these two trials have created a lot of discussion, and there are about 10 review papers published in the last 6 months, which say, should we keep the ESUS construct or should we throw it away? And these people here say, we should leave ESUS. But is it a good idea to go back to cryptogenic stroke? I don't think so. So part of what they say, I think, really makes sense. So, for example, people who have PFO, they should no longer go under the group of ESUS, because here we have a defined source of embolism. And also, I think people who clearly have atherosclerotic plaques which are unstable most probably need a combination of low-dose anticoagulation with aspirin. So I think let's wait for the results of the two ongoing trials, and then we can finally decide whether we keep ESUS as a concept or whether we change it. So this is my overall conclusion. We have two randomized trials which failed to show superiority of NOACs over aspirin in secondary stroke prevention in ESUS. Two trials, Atticus and Arcadia, on ongoing. I think this means that people who are old, above 75 years, people have compromised kidney function, and people who have a high pro-BNP and have a large atrium, in these people we need more regular ECG monitoring. And in my country, we can no longer use implantable devices because they are too expensive. So what we do, we will do Holter monitoring after 3, 6, and 12 months for 7 to 10 days. And the detection rate, by the way, is as good as with an implantable monitor. So we need to modify the concept of ESUS for future trials. patent foramen ovale should be removed from the ESUS population, because here we have a clear embolic mechanism, and we have shown that aspirin is as effective as anticoagulation with a NOAC. And patients with atherosclerotic plaques most probably also need to be removed from ESUS, because if we look at the results for rivaroxaban, most probably these patients would benefit from low-dose NOAC plus aspirin. So thank you very much for listening and watching.
Thank you, Professor Diener, for this comprehensive presentation. Actually, you took us across the whole journey from the beginning. I know you were in this issue. And now I will start. Tell the audience, I wish any of the attendees, if you are having any questions, you can just put it, and then we will take the questions. I will start by few points. It's obvious that ESUS is a heterogeneous group. So would you recommend that we do further investigations to make sure that or to identify those people who are having PFO or having emboliogenic plaques, so which are not fulfilling the criteria of major large vessel disease, or doing more investigations to detect the atrial cardiopathy? So when you will decide to do transesophageal echo, vessel wall imaging, detailed investigations of the heart to pick up those patients?
Yeah, you see, we have two age extremes for two different mechanisms. PFO is much more relevant as a source of embolic stroke in people below the age of 60. So if you have someone who is 45 years old or 50 years old and doesn't have severe atherosclerosis in other territories, like doesn't have coronary heart disease or peripheral arterial disease, you should definitely look for a PFO. On the other hand, if you have someone who is older, above 75 years, and by age has a higher risk to develop atrial fibrillation, I think it's worthwhile to look at the atrium and see whether there is atrial dysfunction, and also take most probably pro-BNP as a marker for more intense ECG monitoring.
Okay. So I will leave the floor for my colleague, Dr. Saeed, to take a few questions.
Thank you, Professor. That was a great talk, and it's actually an honor to meet you. I've been reading many of your publications, and it's actually an honor. I hope one day we can advance our international that we hold the next year in 2021. So my question is given your experience in large clinical trials, would it be doable, and will we be able to recruit a good number with a good sample size too, to study two groups? The first one is, let's go with ESUS only above the age of 70. And so the only inclusion would be having an ESUS and above the age of 70, and we will be saving a lot of money doing these sophisticated tests, because we probably know that most of them, we assume that many of them will have AFib, and do a randomized control trial on them and see if these NOACs will do better. That's one group. The other group is a relatively younger age group, as you indicated, where we will be looking carefully to exclude those with PFOs or atherosclerotic plaques. Do you think it's a study that will be doable with a reasonable sample size?
Yes, the first study, we wrote a protocol, as you can imagine, for the low-dose of the dabigatran in people above the age of 70. And Boehringer was not committed to fund it, because they say, the patent stops in 2 years from now, and we don't no longer invest it. So I submitted this protocol to the German Research Council. Now, this study would require about 750 patients in each group. And the German Research Council said, this is a very interesting question, but Boehringer should pay for it. So this means I have to wait for 2 more years until the patent of the Bigetran goes off, and then I can submit it again to the German Research Council.
Okay.
We also submitted a second protocol which was turned down, and these were people who have atrial fibrillation and atherosclerosis, and we wanted to compare low-dose NOAC plus aspirin with NOAC independent of age, because this is a totally unresolved question whether people who have AF and atherosclerosis would benefit from dual therapy. And unfortunately, this was also turned down.
May I ask, the second protocol you submitted, what duration you choose for treatment to combine the NOAC with the antiplatelet? You chose in your protocol 3 weeks, 3 months?
No, this was permanent.
Okay, I see.
So the study duration would have been 2 years.
I see. Fair enough. Prof. Arif?
There is a question here. Patient with ESUS criteria and his atrium diameter is more than 4.5 centimeter. Would you recommend the rivaroxaban over aspirin?
Yeah, I don't think I would recommend in this case rivaroxaban, because obviously it has a higher bleeding risk than aspirin. So let's say if you really consider in such a patient where you say this patient has a very high risk to develop atrial fibrillation, in this case I would use the low dose of the Bigetran.
Another question regarding also the age. So for the age of 75 with ESUS, also you would go for NOACs directly?
Well, again, you know, it's well, for this subgroup, it was statistically significant. But again, it's always difficult to rely on subgroups if the overall study was neutral. So I cannot really recommend it. I think it's your judgment. If you think this patient has a high risk to develop atrial fibrillation, it's perhaps an alternative.
I can't see. Okay, I will ask a question here regarding the natriuretic factor. When would you ask for this factor? In which group of patient, and also in the vessel wall imaging? You know, this technique is now becoming available in some centers. So would you recommend also a special group of patients in which we can ask for vessel wall imaging to prove that they are having empolygenic atherosclerosis?
Yeah, the one group where I would definitely look at the vessel wall are people, for example, who have recurrent TIAs in the same territory. This is usually indicative of an unstable plaque in the carotid arteries. And there, I think it would be wise to do vessel wall imaging, because then you can immediately see whether a plaque is stable or unstable.
Okay. Professor Said, I guess there's a couple of questions. You can take them. You can see them on the board.
Sorry, I don't. Oh, do I see? I can't see. I can't see the questions. If you don't mind reading them, please.
Okay. There is a question from Kenya. Please comment on the use of aspirin or the Bigetran after surgery. If you study after, how long should it take?
Yeah, this depends on the kind of surgery and depends on the kidney function. So if it was minor surgery, you usually stop for 1 or 2 days. If it was large surgery, and in particular neurosurgery, you have to wait for 4 or 5 days. And then again, depending on the kidney function. So prior to surgery, if the patient has a compromised kidney function, you have to pause longer than if a patient has normal kidney function. But this is all in the ESC, European Society of Cardiology guidelines and ERA recommendations. They have wonderful tables for stopping time to stop before surgery and time to reinitiate after surgery for the different NOACs, different ages, and different kidney functions.
Actually, there is a special situation here in Egypt in different studies in which we are noticing that we are having a lot of patients with intracranial stenosis. Sometimes it's not mounting up to 75%. Let's say diffuse atherosclerotic changes and so on.
Mm-hmm.
So those patients fulfilling the criteria of ESUS, also you would recommend the use of anticoagulant. Of course, we know the different trials, the WASID, the Sampras, and so on. But in that situation, what would you recommend?
Yeah, that's a very difficult question. Whether, these people, the problem is always dual antiplatelet therapy is more effective than monotherapy, but you also have the increase in bleeding risk over time. And this is unfortunately totally unresolved. In particular, as I said, in patients who have both atrial fibrillation and intracranial disease, what to do there. And my tendency, and that's basically also what my colleagues in Asia are doing, because it's much more frequent, as you know, in Asian people. So in this combination, AFib, intracranial stenosis, they also use 1/10 dabigatran plus aspirin or 2.5 apixaban twice daily and aspirin.
There's a question also about the results coming from the subgroup analysis of different trials. Are they significant enough to be added to the guidelines, or still the issue is evolving?
No, at present they have no impact on the guidelines. So the new American guidelines, the modified version just came out. The German guidelines will come out at the end of this year, and they basically say for ESUS standard of care is still aspirin.
Yes. Dr. Saeed, you have any further questions or comments?
Okay, sure. In the case of the combination of intracranial atherosclerotic disease and a apparent cardioembolic source like atrial fibrillation, I think the combination is relatively safe between a small dose like NOAC or warfarin plus aspirin or clopidogrel. But as the Professor Heinz has stated, this is an unresolved issue, and it will need the recruitment will be quite difficult, because you will need a large number of participants to participate in this trial. But it's certainly not for life. I think probably not for life, because the atherosclerotic plaque seems to be stable within like few months. So the combination for a couple of months may be reasonable, I guess.
Yeah. I think that's a very important point you make, that perhaps it's enough to do this for 3 months, because what we know is that if you use combination therapy, whether it's anticoagulant plus aspirin or whether it's 2 antiplatelets, the risk of bleeding increases with time. So if you limit the time, then most probably you have a good relationship between benefit and bleeding risk.
There is a question here regarding the microbleeds. If the patient is having microbleeds with ESUS, would this affect your decision whether to choose NOACs or antiplatelet?
Well, we haven't done this subgroup analysis. We had brain imaging from all of our patients, the majority MRIs. These were not yet analyzed, so I cannot answer you at the moment what the impact of microbleeds is. Our hypothesis is microbleeds are driving the bleeding complications, and this wouldn't necessarily predict a difference in benefit. We know that microbleeds are powerful predictors also of ischemic stroke, but this analysis has not yet been done. Unfortunately, most probably it will not be done, because as you can imagine, for both studies, Bayer and Boehringer stopped funding of future analysis.
There is also a question regarding a subgroup analysis for dual antiplatelet versus NOACs in ESUS.
Yeah, the dual antiplatelet was not allowed. So all of our patients had monotherapy. And if a patient, for example, was on dual antiplatelet therapy, he could not be randomized.
But what is your impression? Because as I told you, we are facing this situation in Egypt, especially with the intracranial stenotic lesions. Sometimes we are putting patients for a long time on dual antiplatelet. What's the recommendation?
Yeah, I think, if I look at the results of the Bayer trial for low dose rivaroxaban plus aspirin, now I'm aware this was a stable coronary heart disease and peripheral arterial disease, but I think the concept obviously shows that low-dose NOAC plus aspirin is superior to either NOAC monotherapy or aspirin monotherapy. And I can't see why this should be different in coronary artery disease and intracranial atherosclerosis. But again, we don't have the data yet.
I can't see more questions. Dr. Saeed, do you have any more questions or comments in your mind?
No, I'm good here. Thank you. No.
So if there is no more questions, we are honored, of course, to have this session and to host Professor Diener with us to open this Neuro Academy. And we promise next time when the Grand Egyptian Museum will open, we will invite you in Cairo.
Great.
Me too, please.
Yeah.
Definitely.
Well, I have been in Saudi Arabia many times. I visited also your hospital 10 or 15 years ago several times.
Yeah. Yes, yes, sir.
So, and of course,
pleasure.
I would like to thank my
Professor Diener, I have a request. Do you mind if I get your email from Professor Arif? You're okay?
No problem.
Thank you very much. I appreciate it. Thank you. I'm on that.
I'm also very thankful to my dear colleague, Professor Saeed Al-Ghamdi, President of the Saudi Stroke Society, and looking for more and more cooperation between Egypt and Saudi and the stroke field. And by this, we will end this session, and looking forward to see you after a couple of weeks with another eminent speaker in this academy. Okay.
Thank you very much.
Goodbye. Goodbye.
Bye-bye.